So hopefully now everyone's being brought back to the main stage. And I'm going to let Nevin Fuchka invite the rapporteurs to report back, and if there's any kind of follow-up discussion linking between the different conversations that were happening in the different breakout rooms, that would be really
I think we can go around the breakout rooms, and if rapporteur can point to the main the discussion points and conclusions, and then we can use that for further discussion. So we can start with the first room on the Olivia, your carbon emission from healthcare systems.
Yeah, I think Tamsin was feeding back on our room.
Yeah.
Well, Olivia, you can also start about what was being discussed in your breakout room, and what are the key points, and what would you think should be next future steps valuable to be considered.
Fantastic. I might be saved by the bell there, and Tamsin might be back.
Okay, well,
are you there, Tamsin?
Yeah, can you hear me?
I think you'll be invited to summarise the key themes and points from our room, and I'm very happy to feed in.
Okay, maybe it will work in a second. But yeah, we had a really interesting discussion. Some of the key points I can talk about was the need to get feedback from healthcare practitioners, especially given current constraints. So it would be great if in surgeries, smaller number of products are used to do the same thing in order to increase efficiency and reduce on waste. But a lot of practitioners have their own preferences, and engagement in these preferences is kind of the key to ensure effective policy. And although a lot of staff are concerned about sustainability, it needs to translate in a way that weaves it in and out of individuals' differentiated capacities. So maybe targeting people in systems with increased capacities, such as those who work part-time. It's about finding the right people for the job. So this feedback system between realities on the ground and healthcare practitioners' experiences and policy is really essential. The second thing we looked at was barriers at the system level. So single-use instruments are historically very important in terms of reducing disease, but as we've seen with the pandemic, the need for reducing disease spread has been pretty paramount. So trying to break down the perception of single-use instruments being the way forward, as well as it being evidence-based, this idea probably needs to be addressed a bit more in research, the fears surrounding single-use instruments or lack thereof. And there's a bit of a binary in the system where it seems like either the environment or patients have to be prioritized, but perhaps we can stress the co-benefits, especially as the numbers for air pollution actually kind of overrode some of the numbers experienced in pandemic admissions rates. So things like that really stress the gravity of the situation at the larger scale climate change. And additionally, the challenges of dispersed versus immediate effects of space and time. Like, this is a challenge the whole system will have to address. We also looked at industry manufacturers. Although there are greenwashing concerns, a lot of them seem quite keen to use sustainability as both a good selling point and also to make a difference. And in order for health technology assessment to be done properly, it kind of needs to happen at the conception stages, and stress the issues of scale and tensions in the supply chain. We talked about that. And lastly, the last couple of points was we looked at increased digitalization. So it's interesting how carbon emissions are kind of invisible in the digital world. And although we've seen COVID pandemic have an increased amount of Zoom calls and things like that, it's actually the procurement of devices that actually attributes to the main impacts on carbon emissions. So perhaps this is something that needs to be addressed more fully. And there are some individual changes in greenhouse gases being made, such as looking at different classic inhalers using different propellants versus dry powders, different syringes, fewer cannulas. Like, these small scale changes in the healthcare, because of how big the NHS is, can really make a big impact. So yeah, just to conclude, some of the potential collaboration points that we talked about was this contention between practice and perception. So the willingness of staff, their preferences and capacities really need to be thought about. Secondly, how useful it is to think about frameworks applied in low-income and middle-income countries. So in some surgeries in India, when they did cataract surgery, they actually would share drugs between 2 simultaneous surgeries. So could this happen in the UK? Or would these models need significant amending in order to be taken into our frameworks? And lastly, there was a question that we thought was a big gap in terms of research, which is this question of how many lives can we save by decarbonising the healthcare system? So data is pretty insufficient when it comes to addressing that question. And very finally, the idea of synthesizing net zero plans is kind of key. So it's one thing to have quite differentiated green plans all around, but this idea of what a good net zero plan is and guide frameworks should hopefully be used for the NHS and beyond. So hopefully that's a good summary of what we talked about. Thank you.
Thank you, Tamsin. Yeah, I think I agree with some of that. A lot of it is myth busting around that you can't have. I think it's a perception that you can't have, if you focus on the environment, that you don't have such good clinical care. But in fact, the two often self-reinforce one another. And we talked about some small scale elements which could be scaled up. And also, I suppose I want to encourage, although there are barriers, and we are seeing a lot of willingness and energy around change, particularly in all. We've got a great policy environment in the UK in particular, and certainly a huge amount of support amongst healthcare professionals, which I think actually is one of the positives from sort of workforce well-being at the moment, which is quite interesting. It seems to contribute to people's work well-being, because it is a very unifying vision, I think, for people to fall into, and gives and seems to give us a huge amount of momentum to their work at the moment.
All right, thank you. Perhaps we can move to another breakout room. Perhaps Ian, could you summarize points that we were discussing in the...
Yeah, great. Happy to, Niven. Hi, everyone. I think you can probably see me. I'll look down to read my notes if that's okay. So our breakout group was talking about healthcare systems and system level responses to climate change. I think we started off just by recognising that the health systems in low-income countries were already under huge amounts of strain and stress, and so the climate change issues came on top of already quite weak healthcare systems. In response to climate change, we talked about some of the key challenges in relation to finance, just paying for changes, governance, who's in a position to make change, but also information weaknesses as well, so that even trying to compare interventions or projects between countries to see what was working was difficult, just because of the difficulty of getting information to test if an impact was working. We talked about just how interconnected the issues are, also about the importance of getting climate change issues onto the health and care curriculum to help the next generation really grapple with these issues. We talked about how policymakers are perhaps the key target audience for trying to get a handle on the issue, and therefore COP26 coming up was going to be a key sort of aspect of trying to push these issues forward. Recognising that for many countries, low-income countries, health and education are perhaps the two major areas of public expenditure anyway. Also recognising that low-income countries have already a much lower carbon footprint per head compared to developing countries, and so it's important to bear that in mind when we're thinking about differences in the different approaches healthcare systems may take. And then finally, on that sort of note, we move towards talking about anchor institutions, and so it's thinking of those as national or major regional players who, because of their spend in a region or country and the employment, the numbers of people they employ, can actually have a huge impact for good in terms of just grappling with some of these issues in an integrated way. But colleagues should feel free to chip in if I've missed anything there.
Thank you, Ian. Mike?
Thank you, Ian, for that nice summary. I think the couple of other things we also mentioned where we have to remember that the populations in low middle income countries are extremely young, and how to engage that younger population, make them more activist, particularly around the environmental side of things, is maybe something worth thinking about. And we also touched on the fact that there may be, to engage in these kind of critical debates, there are obviously experts in many low middle income countries, but the number of those experts is probably relatively small, and that maybe on a global stage that wealthier institutions such as Oxford have a great potential role and responsibility to train people who are technically adept in understanding these debates, and then in their own countries getting those onto the political and health system agenda, because many countries are actively building and developing their health systems, because they're in a weak place at the moment, but they aspire over the next 10, 20 years to be delivering healthcare that begins to parallel that's being provided in higher income countries now. So there are a number of areas for sort of shaping the opinions, as well as everything else. But Nevin, maybe there's something else you wanted to add over.
Sure. I think that perhaps what would be interesting to connect what we've been discussing with the next panel on the health effects of heat and cooling, and what can be not just academically researched as exposure, but also what could be the practical steps. So I will bring the Anand, or who was the rapporteur for that, to you guys bring your information, and then we're gonna revisit everything once more before we stop the session. Okay, Barbara?
Hello. So we discussed the importance of actually getting data from the people on the ground on the effects of climate change on healthcare systems. So not just things like heat, but also things like, for example, flooding or extreme cold or unpredictable precipitation patterns. So one of the main points we discussed was creating a sort of global network which will allow researchers and the people on the ground and healthcare professionals to connect and learn about what is happening kind of on a local scale. So right now we're missing a lot of local scale data. So this network would probably have quite a big emphasis on collecting local data from local scenarios, because obviously solutions will have to be tailored to very specific conditions. And it will have probably two main focuses. The first will be creating a taxonomy of climate impacts on healthcare systems. So that could be, for example, things like the effects of heat on healthcare systems or the effects of flooding, for example. And then the other main aspect would be an overall focus on healthcare system resilience. So kind of once the climate impacts are documented, we will also document the responses of healthcare systems to those impacts, how well those responses worked, whether they need to be changed. And this would be a live, living, real-time network. So as these events are happening, data would be collected and fed into this network. In terms of how it would be administered practically, there are obviously challenges as to where it will be hosted and how it will be funded. So the two main ideas at the moment are either kind of inserting it into the global health network, which is already well established and has a lot of contributors. So this could be kind of a branch of that focusing on the climate effects on healthcare systems, or it could potentially be done in collaboration with the OHDSI. These aren't the only options. But these are two well-established networks which are already sharing data. So in terms of getting people to participate, these might be good options to look at. There's also the idea to kind of perhaps try and focus this network on the global South and Africa and get them particularly involved in the data collection here. The other big points that we discussed was the problem of syndemics. So kind of the idea that what we're facing now isn't actually just one viral pandemic. We're actually facing a host of different pandemics. One of the largest is a pandemic of non-communicable diseases. So most people here probably know that large risk factors for coronavirus, for example, are obesity, diabetes, hypertension, things like that. And there isn't all that much emphasis on combating these often preventable non-communicable diseases. So we were thinking that looking into this area and kind of the comorbidities which occur with huge healthcare problems like the coronavirus or any future pandemics as well is definitely going to be fundamental. Besides kind of the directly healthcare associated comorbidities, there are also problems with things like food security around the world, loss of biodiversity, which will feed back into like diseases of the future and how we administer healthcare. So all of these things will need to be considered and perhaps integrated into this sort of network approach as well. And finally, we also discussed the role of digital technologies and digital data in achieving healthcare goals. So on the one hand, digital technologies can be very effective for collecting the data which will be needed to input into the networks which people are trying to create. We also discussed that digital technologies, especially during the COVID pandemic, have become a lot more widely accepted and used within the healthcare system. So instead of doing consultations face-to-face, for example, people are turning more and more towards remote meetings, kind of like this one. So there's a much lesser demand on actually meeting people face-to-face. And one of the interesting points we discussed about this could potentially be a very good way to facilitate universal healthcare in countries with lower or middle income backgrounds. So where there aren't many resources and there aren't many people actually available to consult with patients, then kind of a turn towards digital technologies might help make healthcare more universal, especially as Mike mentioned, since there's often a short supply of medical staff in kind of rural areas where people are facing the biggest climate impacts. Kind of being able to connect them across much wider distances virtually might help alleviate some of those problems potentially.
That was a really great summary, Barbara. I think much better than I could have done. We obviously discussed a lot of stuff. Only thing I would add in there is I think broadly the framing would be resilience for both healthcare systems and for populations. So resilience for healthcare systems such that if they hit a climate shock or they're hit by a climate shock defined by the taxonomy, they're able to bounce back quicker, and resilience from a population perspective, to Barbara's points. If we're able to keep our populations healthy, they will be less susceptible to both physical and mental health negative impacts from climate change events, which will then translate into less demand or need for healthcare services. That's all from me. Barbara did a fantastic job, so nothing to add to that.
Well, thank you very much. This was all valuable points. And yes, I want to also emphasize that we have to be creative in using already available technology, because we cannot rely that the governments or NGOs will be enough to provide improvements in data collections and for healthcare. So yes, for example, using cell phones, because we know that for example, cell phones structure, towers, and use of cell phones will proliferate far faster through through low and middle incomes countries than what we can do with health services, as well as, for example, satellite data. We're getting more and more high resolution satellite data. From on that aspects, we will be able to gather information about population expansion and perhaps these reports, self-reports, or any kind of things will be providing this filling the blanks. Of course, we have to be aware that data also can be corrupted or misrepresented, but even the low quality data can be more useful than no data at all. So I think this is something that we have to be kind of creative, and the issue is that we have to look at this from a complex system point of view, where the entities will be the driving force. There will be no central command and control, but there will be basically the coherent groups with their interest at different levels, local, regional, and national, that will lead the charge in changes. And especially, like Mike pointed out, the young people that are basically the population structure is changing, and there are many of these countries actually, like if I remember correctly, Mike, you said that in Kenya the almost 50% of population is 20 years and younger, so we have to be mindful of that. Any final thoughts or words that you want to share with us? Any of the group breakout group leaders, please?
Just maybe a final thought from me is, as people are making connections in Oxford, we clearly need to think about making connections outside Oxford. And so finding ways to do that make a lot of sense. And I like the ideas of networks, but networks also need managing, and they're an active process. But it would be yeah, they do provide ways of learning at scale, which are maybe an interesting opportunity. Over.
Only quick comment from me is, yeah, I would agree with Mike that if we're able to get some of the outside centers, if we're targeting Wellcome, one of the things that we discussed in our group was, there's a Wellcome Khemri Center. I think the Thai Center is funded by Wellcome, et cetera, et cetera. So if we were able to bring them together, I think that into this sort of network or collaborative group or community of practice, then I think it could be a powerful framing for Wellcome Trust, where these individual entities would come together. The sum would be greater than the parts, and there could be a lot more sharing of knowledge, etc. And those entities have already been set up for so many years. They have a local established connections. Because this sort of thing, sharing data like what we were discussing in our group, requires trust, and having those established networks on the ground is essential. Otherwise, you're not going to be able to have those honest conversations, which means that you're not actually going to be able to deliver or drive change on the ground.
All right, Olivia, perhaps.
Yeah, thank you very much. I think it's really exciting to have an initial discussion about this, and thank you, Mike, for raising that suggestion about collaborating beyond Oxford, and I think that would be we're certainly aware of researchers doing some really fantastic work on sustainable healthcare, particularly looking at sort of emissions and so on. And yeah, it'd be good to draw those really exciting opportunities to draw those people in, as well as looking at sort of the Wellcome groups within the university that we've got already. I think that will lead to a very strong strategy going forward. Thank you.
All right. Well, thank you, Olivia, and thank you, everybody. I think what we can do in practical sense, the recordings will be shared with you. And now the question is, would you be interested to share your contact informations with the participants of the forum? And let us know. Or I think, Joe, are we going to send a separate email on that?
Yes, there'll be a follow-up email for all the attendees, and I really encourage you to get in touch with someone if there's someone who brought up something that you kind of connected with or you thought was important. And remember there is pump priming funding, that the scheme is open now and it closes on the 24th of November. So if there's something you want to collaborate with someone, please think about applying for that and or come to the final session on Wednesday, which is going to be looking at climate extremes and their impacts on health. Thank you very much, everyone, for coming.
All right. Thank you.